Hi, it's Dr. N, and here we are in our session on gut health talking about SIBO, small intestinal bacterial overgrowth. Now, I send this out to all of my clients who are in a gut module, and that's part of the protocol, whether or not they do actually have SIBO, because it's something that you can get at any time, and we'll talk about reasons why people get SIBO. So even if you don't have SIBO now, or we don't think that you have SIBO now, go ahead and go through this lesson. With some awareness. Number one, you can protect yourself and you can recognize it if it comes on you later, but you may know somebody who has this, and the symptoms are actually pretty easily recognizable, and you might be able to point somebody in the right direction. Now, you may have SIBO, and therefore everything we're going to talk about is relevant, and what we're talking about today in the content is based on our current knowledge of clinical practice associated with SIBO, and I'll be sharing with you my perspective on that. And I'll be showing you some of the things that we're doing from a neurological standpoint, which may not make sense to you in the beginning, but the brain and the brain-gut axis actually have a lot to do with how a lot of people get SIBO and how we actually recover from that. So we're going to break this down into 4 different sections. We'll just make sure that you know and understand what SIBO is, how it happens, the general approach of how you fix it, and the additional element of the brain-gut axis, which is a part of having good success with SIBO that most practitioners are just not even aware that this is a necessary part in most cases of SIBO work. So what is SIBO? Well, it stands for small intestinal bacterial overgrowth, and it is here in 2016 all the rage on the internet, and there's all kinds of discussions and forums and summits formed around SIBO, but SIBO has been around in the medical literature for, I guess my awareness goes back probably about 15 years, and it's probably even before that. So SIBO's been around for a long time. It just hasn't gotten a lot of attention, but now in the age of the internet and sharing of information, it's really kind of risen to the top as things do. If you haven't noticed in the world of natural health and natural medicine, especially when it comes to blogs and the internet, every year there's kind of like a theme or a flavor of the month, if you will, and it's just SIBO's turn recently. So there's a lot of attention. Now there are some books being written on it. I will tell you that there are some names in the world of SIBO that are kind of floating to the top, to use that term again, in terms of being perceived as experts in SIBO. But you don't necessarily have to be a true expert or a self-professed expert to be able to manage these things properly and well. Now with SIBO, even though the bacteria is part of the name, you can actually have SIFO down on the bottom, which is a fungal overgrowth, and that can complicate testing methodologies and our ability to find this stuff. But if we just confine our thought process to bacteria, the bacteria that infect the small intestine can be pathogens, they can be commensals, or they can even be your good probiotics. Now, if you remember back from one of the other gut lessons, there are 2 general kinds of infections you can get. One is pathogens, and those are things that you should never have. Commensal infections are things where you get an overgrowth of neutral bacteria that are part of a normal healthy gut, but they're usually in very low concentrations, but something happens and you lose control of that. But you can actually have infections with your own healthy bacteria, probiotics. I'm going to explain how that happens in just a moment. So that's really what SIBO stands for. Now, most of the bacteria in the intestinal system are crowded towards the bottom of the intestinal system. If you remember back to the first lesson, we talked about how the gut is just a long tube and it's broken up into different compartments, right? So you have your stomach at the top, small intestine, large intestine, and then the colon. And so most of the bacteria exist at the end of the system towards the very far end of the large intestine and the colon itself. And so the small intestine is relatively sterile. There are far fewer, I'm talking on the order of about 1,000 times less bacteria found in the small intestine than in the large intestine. And that's actually a huge number when you realize that in the healthy gut, you've got about 100 trillion individual bacteria spread across about 1,000 different species. And in fact, when you look at the small intestine, which is the largest portion of your intestinal system, probably about, at least 60 to 70% is small intestine. The very upper end of the small intestine, as it comes out of the stomach, has hardly any bacteria at all. Now, the 2 intestinal systems, the large and the small, are physically separated into different compartments, and they're divided by a valve called the ileocecal valve. And it's the name tells us where it is. It's between the ileum and the cecum, and these are two different components or subdivisions of the small intestine, which I'll show you that in just a moment. So what does this ileocecal valve do? Well, it literally provides a physical barrier that separates the small and large intestines, and it controls the flow of intestinal contents, so it goes from the top to the bottom and can't go back up from the bottom into the top. So it's kind of like a check valve that prevents things from the large intestine from refluxing back up into the small intestine. And the ileocecal valve really is a muscle. It's a sphincter muscle. And as long as it stays closed and opens only as food is passing from the small to the large intestine, then we get that very distinct separation of those two intestinal compartments. So having good ileocecal valve function is really very critical to maintaining this normal distribution of bacteria, so that almost all of the bacteria are crowded towards the distal end where we're getting ready to eliminate stuff. So here's a screenshot. This is taken from a chapter in a book called The Microbiology of the Gastrointestinal Tract. Now, this was published back in 1996, but the human gut hasn't changed in the last 20 years, so that really doesn't make any difference. But on the bottom, you see the different divisions of the intestinal system. So we have the stomach, which obviously is the beginning, and then the duodenum, the jejunum, and the ileum make up the three different subdivisions of the small intestine. Now I've added this label here, small intestine. That's not part of the original graphic. But the small intestine is divided from the large bowel or the large intestine by the ileocecal valve, which exists at the end of the ileum and the beginning of the cecum, which is the very first part of the large intestine. So that's kind of the physical divisions of the intestinal system. But what I want you to look at is I want you to look at this solid line right here, and this solid line represents the probiotic or the biotic environment of the gut. And as we get higher on the graph, we have increased concentration or increased number of organisms in the particular location that we're looking at. So if we look at the end of the large intestine, you'll see that we're at the upper part of the graph here, and that means that there's a tremendous amount of bacteria in the large intestine, particularly towards the end. But if we go into the small intestine, you can see that that graph slopes down very quickly, and that there is some bacterial count throughout the entire system. But when you compare the amount of bacteria in the gut and the upper small intestine to the lower small intestine and certainly to the large intestine, you can see very easily that all of the bacteria are pushed towards the end. And that's really good, because here's one of the fundamentals. The bacteria in the intestinal system are living organisms that feed off fermentable compounds in your diet and fibers, so starches and fibers and sugars. And as long as your intestinal system is breaking things down from a digestive standpoint efficiently, and as long as your bacteria are crowded towards the distal end of the large intestine, then the critters don't have that much of an opportunity to feast on the dietary fibers and starches and sugars, these fermentable compounds. And that's a good thing, because if we don't digestively break down these fermentable compounds efficiently, and if the bacteria are scattered throughout the entire intestine, we end up with basically a feeding trough where all of these bacteria, good, bad, or indifferent, are feeding on things and producing gases. And that's really the hallmark of the SIBO environment. So really, what is SIBO? SIBO is where you get stuff in the small intestine where you shouldn't have them, and they feed off these fermentable foods, and they produce a variety of gases. So normal bacterial function and distribution requires, number one, crowding of the intestinal bacterial contents towards the end of the system, and hardly anything in the small intestine, and an efficient digestive process that will break things down so we don't overfeed them and produce problems. Because all of these, as we mentioned, all of these bacteria produce gases. Now, there are several studies, many studies on the gases that are produced by these compounds, but most of them focus around looking at both hydrogen and methane, and that actually becomes part of a SIBO testing approach, is to measure hydrogen and methane. We'll come back to that in a second. But hydrogen and methane have the potential to alter gut motility and bowel habits. So for example, if you have a bacterial profile where the critters that you're feeding in a SIBO situation are producing predominantly hydrogen, this hydrogen has an impact on the intestinal motility that tends to produce loosening the bowels and promotes diarrhea. So if you have a SIBO variant that is more hydrogen than methane producing, you're going to tend to have really loose stools and maybe frank diarrhea. And it could be every day, all day, or it could be intermittent. If you have a bacterial profile where your critters are feeding and then producing predominantly methane, that tends to shift bowel motility and slow it down. And so you may end up with constipation dominant symptoms, or you may have a mixture, either because you're producing both hydrogen and methane, maybe different amounts at different times, or maybe you have a different kind of infection that produces a different gas that we don't even know about and we don't really see anything in the research. And actually, this is quite common with your classic irritable bowel syndrome picture where you get alternating constipation and diarrhea with some cyclical variability, meaning, I may be constipated for a while, but then everything loosens up and it goes too far in the other direction. And then everything gets stopped up again, and that just kind of repeats on, again, some kind of frequency. Interestingly enough, if you look in the medical literature on irritable bowel syndrome, 80% of all IBS cases have SIBO. And what we see in clinical practice is that when we manage clients that have that classic IBS picture, when we fix their SIBO, their IBS goes away. And we've had, just off the top of my head, I can think of 2 clients in our recent past that have both had about 10-year history of IBS, and one of the ladies actually had 10 years of daily diarrhea, and that's just not healthy. Kind of silly to think about, but certainly not a healthy environment. So what I want you to fix in your mind is this idea that there are bacteria in your gut, and they should all be crowded towards the end of the intestinal system, and you need to have really good digestive capacity to break these fermentable compounds down into little teeny tiny bits so that the only time that you really feed the critters is when all of the food is passed through the small intestine, you've done all your nutrient absorption or your vast majority of it, and now at the very end of the process, you feed the critters because they're going to make some good compounds for you like short chain fatty acids, etc. And if you get gas, it's just a little tiny bit right before everything exits the system. But with SIBO, all of that changes. We typically see poor digestion. We don't see full breakdown of these compounds in the intestinal environment. We see a redistribution of these bacterial contents up until the small intestine. And so now we have critters in the small intestine feeding off food that hasn't been broken down efficiently, and they're producing things like hydrogen and methane, and there are other things that we certainly don't know about that we're confident that they are producing. And again, that can cause diarrhea or constipation or some kind of flip-flop where you have that classic IBS picture. So there is a SIBO breath test, but I will tell you, and I probably have shared this with you already one-on-one, we just don't do it. The only time, that's not true. I have run the SIBO breath test, and I usually run it if I have a client that just absolutely wants to see the test. But if we ever run a SIBO breath test, it's with this understanding that if it comes back positive, it confirms you have it. But if it comes back negative, it does not confirm you don't have it. And the reason for that is because there are factors that are affecting the ability of the test to accurately tell us whether or not somebody has SIBO. So for example, one of them is the fact that people have different motility rates. And because the lab test looks at hydrogen and methane before and after consuming some kind of a fermentable compound, and it's measured in time intervals, say 30, 60, and 90 minutes after consuming the stuff that can ferment and theoretically be able to produce gas in these bacteria. But if you have somebody who's got really slow gut motility, you may get to 60 or 90 minutes and not really see anything just simply because the sugars haven't hit where the critters are yet. Or we may have issues because some critters produce other gases. We're measuring hydrogen and methane, but the critters are producing something else that the test doesn't measure. And we know that fungal species don't produce these characteristic gases that we might see with bacterial infections. So the bottom line is, the SIBO breath test, the medical literature basically says that is highly controversial because even on a best day, it only finds about half of the cases that are, confirmed in the research model. So what's the best approach? Well, the best approach is actually a clinical kind of a rule out scenario, rule in scenario. We ask simple questions like, do you have the classic symptoms, which we'll review in a moment? And are those symptoms consistent and reproducible when you eat foods and compounds that are fermentable? Because if you have a SIBO problem, anytime you eat something that's fermentable, you are going to predictably get the classic symptom picture or some version of that, your version of that. And if you take away those foods that tend to produce the gas, you're not going to produce the gas. And so quite often we'll get an immediate change in the classic symptoms with the proper diet change. And as soon as you slip up or put something back in that's fermentable, the symptoms come back again until, of course, you kill everything off and you fix that bacterial distribution problem. So we really rely on symptoms. And I've said to you before in different lessons, perhaps in one-on-one, I don't like to base a lot of things off symptomatology. We much prefer looking at hard data and combining that with what you tell us is happening in real life. But the truth is sometimes the real world scenario tells us more than the testing does because we have no viable, accurate, reliable testing methodologies. And this is the case here. So what are the common symptoms with eating fermentable foods in SIBO? Well, it's gas production, which causes bloating, can cause abdominal distension, and typically some change in motility. Now, these are what we expect, and any one person is going to have a different variety of these things. But again, it's consistent, it's reproducible, and it's responsive to the diet changes. So these are the things that we look for. And when this is present to one degree or another, it gives us a certain degree of confidence that someone either does or does not have SIBO. And so we have to change our gut protocol accordingly based on what we're seeing. So let's move on and ask the question, well, how do you get SIBO? There are many different published models in the medical literature on how people get SIBO. The first one is after acute gut infection. So you can get a viral gastroenteritis. And in fact, this model, I don't have it written on the slide, but this is actually an autoimmune SIBO model. I don't know how many cases there are or what percentage of the total this particular methodology accounts for. I can't give you that data, but I do know that there is a published model where someone can get an acute gastroenteritis, and because of the inflammation and the damage to the lining of the gut, what happens is you can end up creating antibodies. One protein that's identified in the literature is something called vinculin. There are others, but you actually end up creating antibodies against proteins that are involved in peristalsis or gut motility. And so you can get rid of the acute infection, but what you're left with is actually an autoimmune problem that affects intestinal motility. And then things don't move along, and that means that food and critters can sit and brew and stew in the intestinal environment. And this is kind of a difficult thing to manage because you can kill critters, but you're still left with an autoimmune motility problem, and it's very easy just to kind of reacquire a SIBO if that's the case. So after an acute gut infection is one model, and that does for some people lead into a gut autoimmunity that changes motility, brewing and stewing of critters. Now, unfortunately, this is published in the medical literature. We know it happens, but there's no commercially available test for me to confirm in any one case of SIBO that actually is the case. So we just have to piece the puzzle together, right? If all the elements are there and it makes sense, then that's the conclusion we come to. Now, we can also see SIBO happening after any kind of abdominal surgery or trauma. We've seen clients have had bariatric surgery, like reducing stomach size or lap band. We've seen it with people who have had gallbladder surgery. In fact, recently we just had a client who ended up having surgery for a hiatal hernia and came out of the surgery with all of the classic SIBO symptoms. Or we can see it after some kind of trauma, like somebody gets in a car accident and they slam up against, say, the steering wheel and they bruise and damage their stomach. We had one lady last year who's an equestrian, and she was in a horse riding accident where the horse reared up. She fell backwards and the horse fell on top of her, crushed her pelvis, crushed her stomach. She lost her spleen and a whole bunch of other stuff, and she ended up with SIBO as a result of that. So you can get it from acute infections, abdominal surgeries of any kind, trauma to the gut of any kind. But probably more common than those are going to be what I call a top-down or a bottom-up acquisition. A top-down acquisition would be where you're not sterilizing the food in your stomach. If you remember back from earlier lessons, we talked about how important it is to have good hydrochloric acid status. And if you can't acidify your gut, which is part of how you digest your proteins, but it's also how you clean the food that comes in from the mouth, right? If you can't sterilize the stomach, then whatever you're not sterilizing gets passed into the small intestine, and now we're passing infecting material into the small intestine, right? And so if this is the case, we always want to ask, well, where is the low hydrochloric acid status coming from? And we have a list of things that we look for and can evaluate if this is the case. Now, we can also get it from a bottoms-up approach, and that's where that ileocecal valve fails to keep the compartments separate, right? The ileocecal valve being that mechanical separation that should control this bacterial distribution, right? If that fails, then we get things from the small intestine migrating up into the small intestine, from the large intestine migrating up into the small intestine, and that can create the SIBO environment as well. Now, what about treating it? Well, certainly there's a pretty good awareness about SIBO, I think, in most gastroenterology practices. Now, I can't say the same thing is true for internists or for GPs or any other specialties, but my experience has been that most of the practicing gastroenterologists, particularly if they're reading their own research, know about SIBO. And the treatment of choice is an antibiotic called rifaximin. And rifaximin gets kind of mixed reviews. Certainly it can be effective in killing critters, but as we'll talk about in just a moment, that's only part of the process. Rifaximin it's an antibiotic that does not get absorbed into your bloodstream, so it stays in your gut, and it just works locally in your gut, and it can certainly kill critters. The problem is that if all you do is kill critters, you're not doing the other elements of the 4R protocol. So whatever mechanism allowed you to have the SIBO to begin with, just because you kill the critters doesn't mean that you fix the problem, right? The fact that you have critters in your small intestine is a symptom of something else, whether it is failure of your ileocecal valve, failure of sterilization of gut contents coming down from the stomach, or maybe a combination of those, or maybe it's related to intestinal autoimmunity and some of the other published mechanisms. The bottom line is when you deal with an infection in the intestinal system, you have to apply all elements of the 4R protocol, and with SIBO, we have to go one step further, and we'll talk about the brain-gut axis in a moment. So what we see in the literature is kind of mixed reviews of the rifaximin, but one thing that is pretty unanimous is that with using rifaximin, even if you're successful in killing the critter, the recurrence rate of SIBO is almost 100%, which means that if all you do is use that antibiotic to get rid of SIBO, you will eventually get SIBO again, and hopefully that makes sense to you because you really haven't fixed the problem. So people using this antibiotic, some of them may be symptom-free for a few months, some maybe up to a year, but eventually it comes back in almost every single case. So I think we can do better than that just by applying some good understanding of how the gut-brain axis works in the 4R protocol. Now, part of this in fixing SIBO is making sure that you go the next step in terms of diet modification. So throughout this whole program, we start out with a paleo diet because that's where we get our best response just from general physiological changes, control of inflammation, controlling blood sugar. But SIBO requires us to go one step further and to follow what's called a low FODMAP diet. Now, FODMAP is an acronym that stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And these saccharide molecules, these are basically sugar-type molecules. And polyols are compounds that you can recognize easily because they have OL at the end of their name. So things, for example, like xylitol or erythritol, sorbitol, mannitol, all of these are fermentable compounds. And unfortunately, many of these things are being used in kind of like health-related products. You'll see xylitol and erythritol used. Erythritol is a sugar substitute that doesn't affect your blood sugar. Same thing with stevia. In fact, stevia is on our avoid list for SIBO because stevia as a natural sweetener contains several kinds of steviols, and these are fermentable compounds. And so somebody may be trying to get rid of SIBO. They're doing generally okay with some of the choices they're making, but they're using stevia to sweeten their tea or their coffee if they tolerate that. And that would be one factor that can be eliminated to try to get more success. So a low FODMAP diet is really necessary, but here's the hard part. And I want to recognize that the SIBO diet is the most restrictive diet that I can put a client on. And I say that now when something's going to come up in 6 months and we're going to have to go another level. But the low FODMAP SIBO diet is a paleo diet to another extreme, because a lot of the foods on the paleo diet, certain vegetables, certain favorable carbohydrates, and certain otherwise approved fruits contain fermentable compounds called fructans and galactans. And so if you're watching this and we've agreed that we're going to manage your case because we think you have SIBO, you should probably already have that SIBO modification list. Like, what are the foods otherwise normally acceptable that we have to take out of your diet because they're going to feed critters? You should have that list, and if you don't, please absolutely let us know, and we'll get that to you as soon as we can. But typically by this point, you've already got that list. Now, here's something else I want you to think about. There are different reasons why people can eat foods and have reactions or symptoms afterwards. One would be blood sugar problems. Typically, if you blow your blood sugar, eating too much food or things that are too high for your blood sugar control, you're going to get post-meal fatigue and post-meal cravings. Now, that may or may not apply to you. I'm just going through a list of why people get symptoms after they eat. So one might be a blood sugar mechanism. Another one might be based on food sensitivities or frank food allergies. So I eat and I get some kind of an inflammatory response, and maybe it's joint pain and swelling, maybe it's a headache, maybe it's a mood change, right? Those are more immunologically related. But some people eat and they get gas and bloating and motility changes and their gut looks like they're 5 months pregnant. That's SIBO, right? That's not an immune response. And so, sometimes people get confused. Well, why do I have to take out lettuce or broccoli or garlic and onions? It's not because they have food reactions, although they might to those, like from an immune standpoint. It's because these are fermentable compounds that can feed the critters, and we don't want to feed the critters. Going back to this idea of failure of the ileocecal valve, when you eat these fermentable compounds and you get the gas and the bloating, the pressure inside the system from the gas and the abdominal distension actually keeps the ileocecal valve open. Remember, that's a sphincter muscle that should, under normal circumstances, be closed. But if you kind of like blow everything up like a balloon, all the parts get further away from each other, and so that muscle relaxes or gets stretched, and now we have an opening for the food, or for the bacterial contents to go from the small intestine back up to the large. So making sure that you're not eating foods that are causing gas and bloating is absolutely critical to making sure that we keep that closed, that valve closed, and start making a separation between the large and the small intestinal environments. But there is one more thing to fixing SIBO, right? It's not just about the 4R protocol, which we've gone over in another lesson. It's not just about the specific diet modifications that we have to make to say you're starting paleo diet. It's also about the gut-brain axis. Now, the gut-brain axis, if you have not been exposed to this concept yet, which I believe you probably should have at this point, the brain-gut axis is what the medical research, it's the term the medical research uses for the communication system between the brain and the gut. Now, the gut has its own nervous system. It's called the enteric nervous system. And it does have some autonomy, meaning you can sever the connection between the brain and the gut, and the enteric nervous system will still control gut function to a certain extent. But by far, the biggest control factor over gut function is the brain itself. And I'll show you in just a moment a little graphic that says where that comes from. But what is the influence of the brain on the gut? It's four main things, and there's more, but there's four main things. It controls blood flow to the gut, which is critically important for maintaining healthy tissue, right? And this comes important if you've got leaky gut. You need to have good blood flow. So to fix a leaky gut, you have to have a good brain. The brain also controls enzyme secretion. So going back to not being able to sterilize the gut because your hydrochloric acid is low, or maybe you've got maldigestion and you're not breaking down carbohydrates because your pancreatic enzymes aren't working well, and then all of a sudden you have more fermentable compounds available for your critters. Brain controls enzyme and hydrochloric acid secretion. The brain also has significant influence over gut motility, and it has direct influence over the tone of the sphincter muscle of your ileocecal valve. So your brain actually controls valve closure. Now, all of these things have local gut environmental influences. All of these things also can be influenced by thyroid function, but the brain is the big player here. So in order to get rid of SIBO, we have to make sure that the portion of your brain that controls the brain-gut outflow is working well. So where is that? Well, here's a little simple graphic of the brain itself, and this is the outer surface of the brain that we would call the cortex. Now, your nose would be out here. Here's the back of your head. We're looking at you as if we're looking at you from the right, or looking at your right ear, so to speak. Your ear would be somewhere right about here. And of course, different parts of the brain control different things, but this section right down here, where the brain starts connecting to the spinal cord, and imagine the spinal cord goes down through the spine here. This section right up in here is called your brainstem. And the brainstem has 3 different divisions going from top to bottom. You have the midbrain, or what's also called the mesencephalon, which sits right at the top. And the mesencephalon is actually responsible for driving what's called a sympathetic response, or a fight or flight response. That's what makes your heart beat fast and hard, and your respiratory system go up, and your blood pressure go up. So imagine that you're being chased through the woods by a lion and freaking out. Well, that's your midbrain and your mesencephalon working. Now, the lower 2/3, the pons and the medulla, really work together because there's a lot of functional overlap between what these two things do. And together, these two things are called the pontomedullary system, and these control your parasympathetic system. And your parasympathetic counterbalances your sympathetic. So there are times when we need to jack our system up to fight or flee for our lives. There are times when we need to chill out and rest and relax so we can go to sleep and our body can refresh and renew. So we always have this, a little bit of balance of both, right? You never have zero sympathetics or zero parasympathetics, or all of one and none of the other. It's always a balance that's dependent on what your circumstance requires, right? And healthy brain, healthy immune system, healthy hormones help to maintain this balance between your mesencephalon and your midbrain, driving your sympathetic responses, and between your pontomedullary system, which is going to keep everything calm. Well, situated towards the bottom of the pontomedullary system is what's called cranial nerve 10. That's what CN stands for, cranial nerve. You actually have nerves up in your brain aside from your cortex and other things. But the 10th cranial nerve is what's called the vagus. And a lot of you guys have heard of this. The vagus is really one of the biggest outputs from the brain, because the vagus controls everything that comes out that goes to the gut. What I don't show you here is that the vagus also have branches that goes to your heart, goes to your lungs, your kidney, your spleen, your liver. All of your visceral system, all of your organs receives information from the vagus nerve in the pontomedullary system. This is all your parasympathetics. So it's your parasympathetic system talking through the vagus nerve that issues commands to your gut, that talks to the gut enteric nervous system to control things like blood flow, enzymes, motility, and your ileocecal valve. And this is the brain-gut axis. This is of course I designed it. I think it's great. This is a nice little graphic that shows you the different divisions of the brain-gut axis and how the communication process goes. In fact, there's one more element to the communication, and that's where the gut itself talks back to the brain. So this is a two-way communication where it's like a double-lane highway with information going in both directions. So the brain talks to the gut, and stuff happens in the gut, and the gut sends signals back to the brain through a different division of the vagus nerve. Imagine it this way. You have a big electrical wire that has the capacity to send signals in two directions. So maybe inside the casing, you've got two sets of wires. One causes information to go from point A to point B, and the other one causes information to go from point B, back to point A. And that's what's happening with the vagus nerve. It has what we call motor divisions, which is where we issue commands out, and it has a sensory division where it receives information back from the gut into the vagus and into the pontomedullary system. So this is the brain-gut axis just in a schematic standpoint, right? And hopefully you can understand how this works. Now, the vagus itself also is activated not just by information coming back up from the intestinal system, but the vagus nerve connects to the muscles that control your throat, right? So it controls the muscles involved in your gag reflex. It controls the muscles that you use if you gargle. It controls the muscles you use when you swallow, and it controls the muscles that you use when you speak loudly, or you hum, or you chant, or you sing very loudly. So what I'm trying to build here is an understanding for you, number one, of the schematic organization, and really focus in on the vagal system and the motor portion, knowing that anything that drives activity from the vagus is going to have a beneficial input into all aspects of gut function, including motility, enzymes, blood flow, and ileocecal valve function. So here's the deal. If you have a faulty brain-gut axis, part of your deal is you got to do the 4R protocol, and we have to modify for your specific situation. You have to do the SIBO modifications to your diet and get rid of all of these FODMAPs, these fermentable compounds, until we kill the critters and until we fix the brain-gut axis. How do we fix the brain-gut axis? We activate the vagus by using the muscles involved in gagging, gargling, swallowing, and singing loudly or humming loudly, because all of those turn on your vagal output centers, which increases the brain's efficiency talking to the gut, which means we get better blood flow, better enzyme secretion, better motility, and we get efficient closure and maintenance of the separation between the small intestine and the large intestine. So part of your prescription in dealing with SIBO is neurological rehabilitation. It's really to do exercises to get your pontomedullary system working better, to get your vagus to be more efficient, so that at the end of the day, you've got more vagal output to the gut and you're controlling the things that matter in the brain's respect for getting rid of SIBO. Now, we'll be talking about these things in your one-on-one sessions, and more than likely we'll be asking you to either come into the office to do a neurological exam, or if that's not possible, then we have a way to do a self-assessment, and we can give you some feedback on how to put this stuff together. But I want you to get hold of this idea that it's about increasing vagal output, and we do that by doing the activities that require activation of the vagus. Let me give you an example. If I want to increase the strength of my bicep muscle, which is the muscle that allows me to bend my elbow and bring my hand towards my mouth, guess what I have to do? I have to pick up things and bring them towards my mouth. Whether that's a cheeseburger, that's not really going to work, and I probably wouldn't do that anyways. But I'm talking about putting weights in your hands and doing, what are commonly called bicep curls, right? I do the action that that requires bicep activation if I want to make my biceps stronger. So if I want my brain-gut axis to work better, I've got to do the things that require vagal activity. We're doing vagal exercises, or vagal push-ups, if you will, when you're doing any or all of these different activities that you see on the screen. Now, there's one more element. I want to go back to the schematic. I want to focus here on the feedback to the brain portion. So we just talked about how you can activate the vagus by doing other things that the vagus does, and as a result, it will drive more information down to the gut for improvement of gut function. Well, what about doing it the other way around? What if we could stimulate the gut environment and send information back up to the vagus? That would probably be pretty beneficial as well. And the truth is we can do it. Wait for it. Coffee enemas. And yes, I'm being completely serious. Now, you may or may not have heard of this, and you may or may not be going, oh, I can't believe he just said that. Well, here's the deal. Enemas are a great strategy, and enemas have been used, of course, through centuries, if not longer, in human health and wellness. But coffee enemas have a distinct advantage. There are some chemical compounds in coffee that really very strongly stimulate the sensory nerve endings in the intestinal system, right? The sensory portion of the vagus that feeds information back up into the vagus. And with the coffee enemas, you can actually use that to send signals from the gut enteric nervous system up into the vagus, and it adds another element of vagal activity that then drives back down information to the gut itself. So we routinely recommend coffee enemas for our clients, and I'm not going to give you specific guidelines and how to do it and like frequency and all that kind of stuff in this video. We'll make those decisions one-on-one based on your circumstance. But I just want you to understand why, right? It's about driving sensory information from the gut, stimulating the gut nervous system by using compounds in the coffee to activate the nerve endings, and that sends information back up to the vagus. And then the vagus is better able to turn back around and issue commands to the gut for blood flow, enzymes, motility, and then valve function, which is absolutely critical for success. So here we go, gagging, gargling, swallowing, loud singing, and coffee enemas. And I might throw one more in here. I kind of debated whether I put it in the graphic or not, but this gets a little bit complicated. But I want you to think about this. We just talked about doing things, other things that the vagus is involved in. Well, the vagal system, that 10th cranial nerve, also shares connections with the nerve endings that are found in your sinus cavity. Right? So the sinus cavity has sensory nerve endings as well, and that connects to the vagus. And one of the things that you could add into this is using what's called a neti pot, N-E-T-I, and you can buy these in any health food store, most health food stores, or you can buy them online. And a neti pot basically looks like Aladdin's lamp. It looks like a little oil lamp from the old days. And you use purified water, distilled water, and you use some salt solution, and you literally use it to fill your sinus cavities and let it flow through. And as that saline solution bumps up against your nasal lining, it generates signals that fire into the connections with the vagus and actually can drive your vagus as well. So one other thing that you can add here is a sinus lavage or a sinus drainage technique called a neti pot, and that can be done daily or a couple of times a day. So this is just one more thing that you might want to consider doing. But these are vagal exercises. This is a brain-based approach. And remember, to get over SIBO, you've got to use the 4R protocol. You've got to be aggressive enough, consistent enough, for a long enough period of time to kill the critters. But you also have to take away their food, right? So we have SIBO modifications with the low FODMAP diet. And then the final piece of the puzzle is doing absolutely everything you can to stimulate the vagus through gagging, gargling, swallowing, loud singing, coffee enemas, or perhaps even sinus washing and sinus drainage techniques. So let's talk about the neurology exam. Again, if you're local, you can come into the office, and even if you live a few hours away from the office, we have clients that drive in for this purpose on a routine basis. We can do a functional neurology exam where I'm able to observe you and put you through things that are very specific to looking at things that are feeding into your vagal system and whether or not those are working. This is probably the most efficient way for us to help with the brain-gut axis part of the SIBO protocol, is for me to do an in-person neurological exam. Now, I understand that sometimes that's just not possible. We have clients in Hawaii and Copenhagen and South America, and so sometimes that's just not an easy thing to happen. And so what I have designed is a neurological self-assessment, which will be attached to the PDF and the email, as a PDF to the email that came with this particular link or this video lesson. So if you can't make it here, I want you to download that neurological self-assessment, and I want you to go through that and send it back to me as soon as you can. And then I can put that together, and I can help you put together kind of a rehab program that may go beyond just gagging, gargling, and singing and coffee enemas, because sometimes there are additional things that can be done from a neurological standpoint that will get even better results. So if at all possible, make arrangements to come into the office if you haven't already done that. If you can't do that, then make sure you download the self-assessment, fill that out, do your own self-testing, get the information back to me, and then we'll work together to try to create a program that's going to work more efficiently than just doing the other elements by themselves. So feel free to go back and listen to this one again. The SIBO, again, it's a hot topic these days. Make sure that you understand the fundamentals and how complete this approach needs to be, and then let's talk in your one-on-ones. Take care. We'll talk to you soon.